Welcome. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology here at the Cleveland Clinic. And I'd like to welcome you to another episode of Rheumatology Virtual Grand Rounds. These are problem-based cases highlighting some of the hottest topics in rheumatology. And today I am really delighted to have my good friend and colleague, Elaine Husni, who is the Director of Arthritis and Musculoskeletal Treatment Center here at the clinic, to talk about an area of great interest to all of us and an area where she has done some spectacular work, and that is managing cardiovascular comorbidity in patients with rheumatoid arthritis. Elaine?
Thank you, Dr. Calabrese, for inviting me to another Rheumatology Virtual Grand Rounds. Today, I will be talking about managing cardiovascular comorbidity in patients with rheumatoid arthritis. Here's a list of my following disclosures, although they do not have any direct impact on the formulation of this talk or the content of its presentation. My learning objectives today will be looking at highlighting the cardiovascular disease as a major impact for patients with rheumatoid arthritis. We'll be discussing some approaches to predicting cardiovascular disease, as well as potential areas of cardiac risk management, and also describe the relative contributions of traditional and novel cardiac risk factors in rheumatic diseases. So let's start off looking at the overall systemic rheumatic disease and cardiovascular risk. So we know now that there's increased cardiovascular risk have been well studied in the following systemic rheumatic diseases on your left, such as RA, lupus, psoriatic arthritis. However, in other rheumatic diseases such as giant cell arteritis, there has been no increased cardiovascular risk. And then there's additional vasculitides that have not been as well studied, such as polyarteritis nodosum. So looking specifically at rheumatoid arthritis, I wanted to spend a couple minutes on the cardiovascular disease and what we know. So worldwide treatment for rheumatoid arthritis has remarkably improved with the use of targeted therapies. However, survival in these RA patients still remain decreased compared to the general population, despite all these great therapies. And this is in part due to excess deaths from cardiovascular disease in these patient population. So when we look specifically at cardiovascular risk in patients with RA, how does this contrast the general population? So in the general population, we look at things like cholesterol levels, diabetes, hypertension. However, if we adjust for all of these traditional risk factors, it still doesn't fully explain the excess cardiovascular risk in our RA patients. So we believe that there's both traditional as well as novel cardiovascular risk factors that may play a role in accelerating atherosclerosis or cardiovascular risk. So beyond these risk factors that we just talked about, we also believe that probably the inflammatory state or the chronic low-grade inflammation that can occur with our diseases, as well as immune activation, can also likely promote cardiovascular disease. So turning our attention to our case that we are starting with, we have a 37-year-old part-time nurse who was diagnosed with rheumatoid arthritis 5 years earlier. She recalls her joint symptoms began after the birth of her first child, where she was getting more and more morning stiffness, lasting more than an hour. She also would be getting occasional joint swelling in her MCPs bilaterally. She tried complementary medicine for several years. However, despite acupuncture and other dietary supplements, she was having continued joint pain. Due to family planning issues, she did not want to go on any DMARDs at that time until about a year ago. Her past medical history consists of some reflux disease that she treats with over-the-counter Pepcid. She was diagnosed with some mild postpartum depression after her first child. The medications that she did decide to go on after her childbearing year, she is on methotrexate at 7 tabs once a week, folic acid daily. She does take a vitamin D supplementation at 2,000 units per day, and she takes Celebrex on occasion. She has no known drug allergies. Her review of symptoms is significant for greater than 2 hours of morning stiffness, some dry eyes. Otherwise, everything else was unremarkable. Her family history: her mother is healthy and alive. Her father does have dyslipidemia. She has some siblings. She has a sister with hypothyroidism, a brother who's otherwise healthy, and an aunt with lupus. She's a former smoker who quit about 10 years ago, but she does smoke occasionally, but not even half a pack per month, she states. So on physical exam, her temperature is normal. Her blood pressure is mildly elevated at 135/90, respiratory rate at 14 with a pulse of 88. She has no skin rashes. On head and neck exam, she has no eye redness. Her oral pharynx is a bit dry. She does not have a salivary pool. Her chest is clear to auscultation. Her cardiovascular exam shows a regular rate rhythm. No murmurs were noted. On musculoskeletal exam, she did have some significant bogginess over her second and third MCPs on both her right and left hand. She has some tenderness over on the balls of her feet, and she has a 5-degree flexion contraction of her left elbow. On laboratory analysis, her pertinent positives are elevated rheumatoid factor at 212, as well as an elevated anti-CCP antibody. The rest of her labs were unremarkable, including a normal CBC and CMP. So she presents for a follow-up visit with you, and she tells you that her older brother had just recently suffered a mild heart attack. She has growing concerns about her heart health and asks what her risk for developing a heart attack since she's had many years of rheumatoid arthritis. Question 1. Which of the following recommendations should be given to best address her heart health? A. Consult cardiology or preventative cardiology. B. Check fasting lipid panel. C. Consult lifestyle modifications such as weight loss if overweight or smoking cessation if she's a smoker, for example. Start an antihypertensive medication. E. Choices are to include A, B, and C. Or F. Choices to include all of the above. So the best recommendation for her is A, B, and C. To consult with a cardiologist or a primary care, check fasting lipids, and to consult on lifestyle modifications. So further discussion on this question is that traditional cardiac risk factors should be addressed. Now, we could do this either in your own rheumatology practice with the help of maybe a primary care referral or with the help of a cardiology or preventative cardiology referral. This will all be done differently depending on the type of practices and referral patterns that you have in the area that you practice. But it is important to recognize and to let the patient know that traditional cardiac risk factors should be addressed. These will include checking your fasting lipid panel, counseling on lifestyle issues, and maintaining a healthy blood pressure. Regarding the blood pressure issue in our particular patient, she had one mild elevated reading on one of our visits, would not warrant initiating antihypertensive medications at this time. We do suggest monitoring of blood pressure readings over time with either the help of the primary care provider or cardiologist or home monitoring. Dietary counseling as well as review of current medicines should also be performed initially to look for additional causes of mild elevation in blood pressure. So going back to look at these risk factors in RA, we do now know that there's convincing evidence from epi studies indicating that RA is an independent risk factor for accelerated cardiovascular disease, and despite adjusting for traditional risk factors, that this still holds true. So in a larger study with rheumatoid arthritis from Van Durham looking at over 20 observational studies, it demonstrated an increased standardized mortality ratio from 1.7 to 3.3. there was a decreased life expectancy of up to 18 years. And recently, 3 larger prospective observational trials had confirmed this finding. For example, there was a nurses' health study with over 100,000 patients, 527 confirmed RA cases in this cohort, totaling over 3,600 cardiovascular events. And this led to a relative risk for myocardial infarction or heart disease of 2.0, so an elevated risk for patients with cardiovascular disease. So the precise mechanism for this remains unclear. However, the other interesting factor is looking at seropositivity. So looking at anti-CCP positive autoantibodies. So in our particular patient, she did have an elevated CCP. In this particular study, was looking at over 290 patients who were anti-CCP positive compared to over 600 patients who were anti-CCP negative, looking at the different cardiovascular events. And what they found is that ischemic heart disease or cardiovascular disease showed an increased odds ratio of 2.76, so a statistically significant difference between those that were anti-CCP positive and those that were anti-CCP negative. So this is a favorite cartoon of mine taken from a New England Journal article in 1999 by Ross et al. And this really helps depict and help us understand what is really going on a vascular level and what's changing in the world of atherosclerosis. So due to this new understanding of atherosclerosis as an inflammatory issue, there has been further identification of risk factors that drive atherosclerosis, mostly in the inflammatory world. And as you know, rheumatoid arthritis is a highly inflammatory condition, and perhaps these combination has increased the risk of atherosclerosis in our patients. So starting in the upper left-hand corner, you see a more cartoon drawing depicting the endothelial cell layer, which is one cell thick and has point-to-point contact. And one of the initial stages is that there's an increased endothelial permeability. So the cell-to-cell contact begins to allow for other leukocytes to migrate through. And if you turn your attention to the upper right slide cartoon drawing, you'll see that when this occurs, you get foam cell formation, T cells get activated, and more entry of leukocytes in between that endothelial wall and the rest of the vessel walls. And as you go down to the lower right column, you see further macrophage accumulation and formation of what we call the necrotic core, and the beginnings of a fibrous cap formation really protruding into the lumen and causing what we know as atherosclerosis. And as you go to the last cartoon drawing on your lower left, the most feared complication, which is a myocardial infarction or plaque rupture, which occurs when the fibrous cap becomes more and more thin, and then eventually the plaque ruptures, and hemorrhage from the plaque occludes the lumen, causing a myocardial infarction. So our world of investigation has been looking at what can accelerate this atherosclerosis, this formation of this necrotic core, and then what causes plaque rupture. So there are risk factors that we know of, some that are non-modifiable, such as increased age or male gender or hereditary, versus those that are modifiable, which you see a list on your right-hand side. So specifically in rheumatoid arthritis, what are the classic risk factors? So we know hypertension, and these can be increased by the use of some of our meds, such as NSAIDs and steroids. Smoking has been also a risk factor in the development and severity of RA. Diabetes and increased insulin resistance, obesity, as well as metabolic syndrome, which we'll talk about a little bit later. In addition to these traditional risk factors, there's also novel risk factors that we should mention in rheumatoid arthritis. We can see elevated levels of homocysteine, elevated levels of TNF, and as you can see on this list, these are some of the more novel cardiac risk factors, some of which I'll talk about later in the talk, that have been possibly associated with our increased risk as well in this population. So let's turn our attention back to this case study, and what is the role of traditional risk score calculations for patients with rheumatoid arthritis? So A, the Framingham risk score will help predict her true risk in our patient that we just spoke about today. B, using the Reynolds risk score will improve her prediction for cardiovascular disease because it also includes the CRP level in this newer risk score. C, her risk is probably equivalent to the general population, as she does not have all of the traditional risk factors such as smoking or diabetes risk equivalent. Or D, Framingham risk score may underestimate her true risk. So question 2, the answer is D, Framingham risk scores may underestimate her true risk. So conventional predictors that we use in the general population are probably inadequate for estimating the risk in our RA population. So how do we assess patients' risk for cardiovascular events? So there's 3 ways of looking at this. One is the risk stratification in healthy populations and using that. The risk stratification in men versus women. As you know, there are many more female patients that get rheumatoid arthritis, and how does that affect our risk stratification? And then more specifically, are there any risk stratifications specifically for the rheumatoid arthritis population? And the answer is that there's probably a combination of traditional, novel, as well as RA itself, inflammatory arthritis risk factors that we would need to take into account. So it's important to go back to see what's going on in the general population in terms of primary prevention. So primary prevention are those patients who have not suffered any cardiovascular events, and what we look for in terms of risk intervention. So here is just to remind us the risk of the traditional risk factors, smoking, blood pressure, etc. You can see the list here and what the goals are in order to reduce your cardiac risk. So this is a slide looking at a 10-year risk of developing hard outcomes of myocardial infarction and coronary death. This is a risk assessment tool known as a Framingham risk factor that looks at estimating your 10-year risk. So you look at the risk factors and you plug them in, whether you're male, you're female, what your age is, what your cholesterol is, and this will give you a calculation of low risk, less than 10%, intermediate risk, 10 to 20%, or high risk at greater than 20%. And this is well known as a Framingham risk factor. A newer risk prediction model is called the Reynolds risk score. And the reason how this is different is that it does also include a CRP that can be calculated in this, as well as taken into account gender, as well as some family history. So it does ask whether your mother or father had a heart attack before age 60. So it does add the family history and the CRP levels. So what is the usefulness of these risk scores for patients with RA? So these are the standard tools for estimating cardiac risk factors in the general population, and unfortunately they do underestimate in our population. For example, the observed cardiovascular rate in women with RA was double when that predicted by framing scores alone. So inflammation is widely believed to be a contributing factor, but using either the Reynolds risk score did not really improve our ability to predict who would develop cardiovascular disease. So further research is really needed in this area. In addition, there is an article from Annals of Rheumatic Disease highlighting the EULAR recommendations for cardiovascular risk management. So there has been some consensus groups that are trying to get together to try to really wrap our arms further along our specific patients with RA and what we can do. I wanted to highlight, there are 10 recommendations. I wanted to highlight 3 that I thought were pertinent to this talk. That adequate control of disease activity is necessary to lower the risk. Number 3, cardiac vascular risk assessment should be done just as a national guidelines recommended for RA patients at least annually. And number 4, which I thought was very interesting, was risk score models should be adapted for patients with RA, meaning that they would multiply the factor by 1.5 if a patient has RA. And RA is defined here as disease duration greater than 10 years, autoantibody positive, and extra-articular manifestations. So this was a little bit going deeper into patients with rheumatoid arthritis and what additional things that we could think of. In addition, another article that was done in 2009 by Peters et al. Looking at whether or not rheumatoid arthritis has an equal to diabetes in terms of independent risk factors. So what this concluded is that the risk of cardiovascular disease in RA was significantly elevated compared to the general population, comparable to the magnitude of type 2 diabetes. So question number 3, The patient has growing concerns about cardiovascular disease, and she heard that aspirin is protective for the heart, and she would like to know if she should start aspirin therapy. So the question is, which of the following statements about aspirin is most accurate for this patient? A, aspirin use is well established for primary prevention of cardiovascular disease. B, aspirin use is unclear in this particular patient as the risk of GI bleeding must be weighed against cardiovascular disease benefit. C, aspirin doses at 325 milligrams compared with 81 milligrams would be more beneficial in patients that are high risk, such as RA patients. D, increasing evidence exists in subgroups such as the elderly and RA patients that chronic aspirin therapy at 81 milligrams per day has unequivocal beneficial evidence for cardiovascular benefit. So the answer is B. Aspirin use is unclear in this particular patient as the risk of GI bleeding must be weighed against cardiovascular disease benefit. So let's look a little into aspirin as cardioprotection. So we know now that aspirin use at 81 milligrams per day is well established in secondary prevention. That means somebody who's suffered a cardiovascular event. However, in primary prevention, where there's no prior history of a cardiovascular event, is much less clear. So regarding primary prevention, the risk of bleeding from chronic aspirin use, along with the other medications that we sometimes use in RA patients, such as NSAIDs and steroids, may or may not outweigh the cardioprotective benefit, and treatment decisions must be individualized in these cases. Low-dose aspirin at 81 milligrams is seen as beneficial as the standard 325 milligrams. So thus, low-dose aspirin may confer less gastrointestinal bleeding risk at 81 milligrams. And so the overall risk of GI bleeding, though, however, it's still important to note, is usually twice as high as without aspirin therapy. But it is now well accepted that low-dose aspirin at 81 is just as beneficial as 325, but since 81 has less of the GI bleeding risk, it is the preferred dose for cardioprotection. Many studies regarding aspirin use in secondary prevention unfortunately did not include women or elderly or patients with chronic illness, and therefore difficult to apply in our population. So further studies specific to this population with chronic inflammatory aspirin would be very helpful and provide greater insight into the role of aspirin in our population. So sticking with our case, this patient comes back for a follow-up visit and tells you that she's now requiring NSAIDs on a daily basis. She used to only take it a couple times a month, but now she really needs this daily in order to get through her activities of daily living. So which of the following precautions for chronic NSAIDs use is most accurate for our patients? A, to take the lowest possible dose in the shortest duration as possible. B, monitor blood pressure carefully while you are on chronic NSAIDs. C, selective COX-2 inhibitors are a safer choice in our patients than traditional non-selective NSAIDs. D, all of the above. E, choices A and B. So the answer to question 4 is E, choices A and B. So looking at NSAID therapy, chronic, has been controversial. It is one of the most commonly prescribed pain relief for patients with arthritis, despite the known toxicity. There has been a black box warning that exists for both prescription and over-the-counter NSAIDs regarding potential cardiovascular and GI side effects associated with its use. In 2007, we also know that the FDA has issued an advisory that low-dose aspirin use may interact with ibuprofen in that it might negate the cardioprotective benefits of low-dose aspirin when there is chronic NSAID use in the same patient. It is unclear whether selective COX-2 inhibitors are equivalent or safer than non-selective NSAIDs. We do now know that there is a very large trial called Precision trial that you can find on clinicaltrials.gov. This is first-of-its-kind prospective randomized clinical trial comparing the cardiovascular safety of 3 different nonsteroidals, celecoxib, ibuprofen, and naproxen. Its plan is to enroll over 20,000 patients followed for up to 3 years, assessing true cardiovascular endpoints, adjudicated endpoints, as well as looking at some typical arthritis outcome measures. Hopefully the next time that I am able to do a virtual grand rounds, I will have more information on this trial, trying to answer a question that clinically right now is very controversial in terms of which NSAIDs would be the safest in our population. So overall, right now, we need to balance the benefits and risks of chronic NSAID use. Little data exists specifically comparing the efficacy of pain pharmacotherapies for patients with RA. Given this clinical uncertainty, NSAID should be used with caution in patients with RA, while highlighting the need for extra vigilance in terms of patients with established cardiovascular risk or risk factors for its development in chronic use in RA patients. So we'll end now with a couple slides looking at what I think are additional investigations that should be considered in our patients. That is looking at improved lipid profile, both LDL targets as well as dysfunctional HDL. What do we do about measuring CRP? What do we do about metabolic syndrome? Are there any early detection that we could do with using non-invasive cardiovascular imaging, and more aggressive use of biologic DMARDs and what that does to cardiovascular risk? So looking at the National Cholesterol Educational Program Expert Panel, the ATPC-3, the identification of LDL cholesterol and therapy aimed at lowering this at certain endpoints are its primary target of therapy. The intensity of risk reduction therapy, meaning how low do you want your LDL goal to be, should be adjusted to the person's absolute risk. So anyone with an elevated LDL is treated with lifestyle changes, and patients that are at particularly high risk are going to be candidates for drug treatment, or specifically statin treatment. So we also know that population-based studies here is looking at HDL, not LDL, that in the Framingham studies that we see an inverse relationship between the levels of LDL, or the good cholesterol, compared to clinical events. So here we do note that the higher your LDL levels are, the better for your prospective cardiovascular risk. And this has turned our attention to why does HDL, the good cholesterol, have protective mechanisms. We also know that HDL is a very complex molecule with multiple, as you can see here, functions. The one that we are targeting is reverse cholesterol transport, which promotes cholesterol efflux, allowing it to have some of the beneficial cholesterol impact. We also know now that it's HDL functionality, so how the HDL functions becomes even more important than just the level itself. And HDL may provide cardiovascular benefits by promoting this reverse cholesterol transport from macrophages, and it can also serve as a predictor of atherosclerotic burden. So you will see more and more investigations on cholesterol efflux capacity. Now, turning our attention to CRP, what's the value of CRP measurements in our patients? It's well accepted in the general population that CRP can help predict cardiovascular events in men and women with and without heart disease. Looking at the RA synovium and atherosclerotic plaque sharing many of the similar inflammatory cytokines, the issue becomes many of our patients had elevated CRP just due to their chronic inflammatory state, and what role inflammation plays in heart attacks and strokes in RA patients specifically that have elevated CRP as well. In the general population, there was a landmark study called the Jupiter trial, looking at greater than 17,000 individuals with low levels of LDL, meaning normal LDL lipid targets, but they had an elevated CRP. So they randomized this group to receiving rosuvastatin and placebo. This trial was ended prematurely due to its positive effects, where they showed that the treated group had a 44% reduction in major cardiovascular events, and those are listed here: MI, stroke, arterial vascularization, as well as DVT-PE, as well as reduction in mortality. And furthermore, to say that within the Jupiter subsets, that the greatest absolute risk and the greatest risk reduction was observed those with the highest levels of persistent pro-inflammatory response. So this becomes very interesting in looking and thinking about our population that has a very high persistent a pro-inflammatory response as well due to the underlying disease. And clearly here you see a pictorial looking at those on placebo, those on rosuvastatin, and seeing the 44% reduction in the group that was treated with rosuvastatin. And reminding everybody that these are all patients with normal LDL levels. Metabolic syndrome also becomes important. This is looking at risk factor clustering, the concept of visceral fat accumulation, meaning your fat in your abdomen, central fat versus subcutaneous fat, and the role of adipocytokines, which are fat cells. Looking at benefits beyond LDL lowering, we want to also look at something called metabolic syndrome. This has been known as a secondary target of therapy. Metabolic syndrome is really the clinical identification of a clustering of risk factors. So here we talk about abdominal obesity, and it gives a waist circumference of men versus women. We also look at triglyceride levels, whether or not they're greater than 150. We also look at HDL cholesterol in men versus women. We look at blood pressure as well as fasting glucose. So the metabolic syndrome is looking at identification of these risk factors in this table. So here is an analysis, a meta-analysis done on metabolic syndrome, just reiterating the fact that the analysis strongly suggests that metabolic syndrome is an important risk factor for cardiovascular disease, both incidence as well as mortality and all-cause mortality. So this leads us to think about measuring subclinical atherosclerosis, how we can detect them sooner. Where one of the things that we are doing is looking at carotid IMT and looking at the intima media thickness greater than 1 millimeter would signify an increased risk. Here are actual ultrasound imaging that we see to measure intima media thickness. Here you can see on the left-hand side a normal IMT at 0.45 millimeters, and on the right-hand side you see an elevation of IMT at 1.2 millimeters, and also pointing at plaque formation. So then the question becomes, should this patient be started on an anti-TNF therapy to try to improve their future cardiac risk? Unfortunately, we cannot answer this question directly today, but this remains an important area of investigation. Current observational studies have found some positive cardiovascular benefits in those that are treated with anti-TNF versus those that are on a non-biologic DMARD. However, these studies have been not consistent, and there are many challenges in this that I named. Some are that many of them are not powered to detect the modest changes in cardiovascular disease. There's short-term follow-up. As you know, obtaining myocardial infarction revascularization issues happen over long periods of time. There's also an issue of confounding by indication, meaning those with RA that have more aggressive disease or tend to be treated with anti-TNF, and so sometimes we can confound our treatment populations more by the indications of their aggressive disease state rather than just simply to their treatment use. And aspirin, whether or not aspirin was used in these studies, also become important in terms of cardiovascular benefit. So we will still need to look further at this issue before we can start prescribing anti-TNF just for the sole purpose of cardiovascular benefit. Really, we should be prescribing based on the RA disease state. The clinical implications for this as we end our talk today: RA may serve as a unique model to study chronic inflammatory burden, and the potential inflammatory modulation in RA may provide insights in halting atherosclerosis in inflammatory arthritis, and perhaps maybe even to help with the general population. Overall summary, I hope that this virtual Grand Rounds has helped to convince you that studies do support that inflammatory disease have an increased risk of cardiovascular disease and early morbidity, that traditional cardiovascular risk assessments need to be adequately addressed in RA. There should be more RA-specific prediction tools to help us with this. There is a consensus that is needed for the ideal subclinical measure. I did show you an example of IMT, but there are many others that are being currently investigated. Further clinical trials to define the impact of immunomodulatory therapies or tighter control of RA disease on cardiovascular outcomes are needed. Thank you again for listening to another edition of Rheumatology Virtual Grand Rounds.
Thank you, Elaine. That was terrific. You know, there are so many takeaway messages here. I'd like to just make a few. I think we're at a very pivotal point in rheumatology where rheumatologists are faced with how they will interact with patients in terms of managing comorbidities. This is just one of them. Another example I'll mention is vaccinology. You know, can we really turf this over to primary care physicians who are intimidated by the drugs and the diseases that our patients have and really are not in the best positions to make those types of decisions? Similarly, with underlying rheumatoid arthritis or other forms of inflammatory arthritis or lupus, the risks of cardiovascular disease are best appreciated by the rheumatologist who is staying abreast of the epidemiologic and underlying translational research. So my vote is that we need to be more proactive. We need to be doing the screening, and we need to be modifying those risk factors that can be modified and treating adjunctively with statins and other medications as needed. If it's complex, I think you need to work with a cardiologist who is interested in preventive cardiology to optimize care. So thanks, and I'd like you all to come back to check out many more installations in this series and come back to the website again. Thank you.